Okay, I'm setting up the recording. Thank you for your patience. Um, all right, so like to introduce our speaker today. His name is Philip Polychroniou, and he is from Clarkston Community Health Center at Emory University School of Medicine in Atlanta. Today, he's going to talk to us about his recent paper that was published in the Journal of Student-Run Clinics entitled A Student-Run Free Mental Health Clinic for the Immigrant and Refugee Population in Clarkston, Georgia. We're really excited to hear about how he helped develop this mental health clinic. As I know, in most of our free clinics, mental health is a huge need, and any tips or tricks that we can get to help improve our clinics around the country is definitely welcome. So please enjoy this presentation by Philip, and I'll turn it over to you now, Philip.
All right, thanks, Amber. I'm going to share my PowerPoint now, and just let me know that you guys can see it. Just give me a second here. All right, can you guys all see my screen now?
I can see your, yes.
Okay, perfect. So like Amber said, we're going to be talking about a mental health clinic that a few Emory medical students and I set up down here in Atlanta. Unfortunately, Celia Foster could not be with us today, but she was the first author on the paper. The other authors were Dr. Martha Ward and Dr. Ann Schwartz, both of whom are program directors at the psychiatry residency program here at Emory. So let's get started. So just as a background, I wanted to talk a little bit about refugee mental health broadly in the U.S. The United Nations defines refugees as people who have had to leave their home country due to persecution, conflict, violence, and other reasons. Since 1975, the United States has welcomed over 3 million refugees to this country. There have been a lot of meta-analyses regarding the mental illness faced by refugees in the U.S., and there is some variation in their findings, but the underlying fact is that refugees have higher mental health burdens than the American-born population. So there are rates between 13 to 86% of PTSD, depression is 6 to 80%, anxiety 20 to 88%. And the prevalence of suicidal behavior ranges between 3 and 34%. The prevalence of mental health conditions among immigrants is a little bit less clear. In fact, there is some evidence that suggests that non-refugee immigrants have lower mental health prevalence than their American-born counterparts, but there is some evidence that suggests that the longer that immigrants stay in the U.S., that their mental health burden rises, which is interesting. Despite the obvious high need for mental health care among immigrants and refugees, we actually access mental health care in the U.S. at lower rates compared to the general population. There are numerous cultural and structural barriers to this, but one study found over 60% of responders say that cost is the most commonly cited deterrent to accessing mental health care. And that's something that we're going to be talking about as a free clinic. Introducing mental health services to that is pretty key, given that cost is such a big factor. There are also some unintended negative consequences that come with providers from higher income countries treating patients from low and middle income countries without a full appreciation for the relationship between the patient's individual culture and their presentation. And this is particularly true in mental health care, in which there's a critical interplay between the culture and the presentation of illness. So in order for mental health care to be effectively delivered to this population, it's really important that the providers not only provide a linguistically matched services, but also deliver their care in culturally sensitive and humble ways. So the Clarkston Community Health Center is in Clarkston, Georgia, which is about 10 minutes outside, or 10 miles outside of Atlanta. 10 minutes if you're on the highway without traffic. There are over 40,000 refugees that have arrived from around the world and have settled in Clarkston over the past 25 years. And there was a survey done a few years ago that found that 46% of the residents of Clarkston are foreign-born. CCHC was founded in 2013 with the main goal of providing primary care and urgent care services to a low-income, uninsured population in Clarkston. And because of the location of the clinic, most of our patients are immigrants or refugees. There is a Sunday primary care urgent care clinic for 4 hours that sees about 50 patients every week. And there have also been specialty services that have been integrated into the clinic, including ophthalmology, dermatology, women's health. There's a dentist who comes once a week. But there hasn't been a primarily mental health clinic until our team of medical students kind of took this on. So hang on, sorry about that. So the establishment of the mental health clinic, this came out of a perceived need from the CCHC staff and volunteers who just realized that so many patients were coming into primary care clinic with primary mental health or somatic complaints. And so there was something that needed to be done to address this need. So basically, the board at CCHC approached some of the medical students who were volunteering at the primary care clinic and asked if they could start the process of setting up a mental health clinic. So the main goals of our clinic were obviously to address the need for mental health services among the patient population at CCHC, but also to provide both medical student and resident volunteers opportunities to work with ethnically and culturally diverse patients without needing to go abroad. There's a big push within psychiatry for global mental health training, and a lot of residency programs have affiliations with places around the globe that they send their residents to get that training, but we thought that this would be a cool domestic opportunity for our students and residents to interact with such a diverse population. So the first thing that we had to do was recruit providers. The board at CCHC had connections with psychiatrists in the community, and we were able to recruit 2 of them to volunteer at the clinic. And we held our first clinic in December of 2017 for 2 hours on a Saturday morning. So we wanted to make sure that we had enough space, so that's why we didn't hold it on a Sunday, even though we were a little bit worried that having a separate mental health clinic on a separate day would be a bit stigmatizing. We just needed the space, and ultimately that hasn't been a factor. We've had about like a 15 or 20% no-show rate among our mental health clinics in total, which is actually, we're pretty happy with that. So once we recruited the providers, what we needed to do was screen patients at the primary care clinic to identify who needed mental health services. So the screening tool that we used, let me move this window just so everyone can see the name. So we used the PHQ-2 for depression, the GAD-7 for anxiety, and the PTSD-5 for PTSD, which is a primary care screening tool that we found on the VA website. All of these are available for everyone to access. We only screened patients using English language forms, which is something that I'm going to address later. But we did have volunteers who were able to translate these forms with our patients. We have volunteers who speak Arabic, Hindi, Urdu. So there's some patients that were able to translate if they didn't speak English well enough to fill out these forms. If there was not a interpreter available, then we just had the patient leave the screening form blank, and then hopefully the next time they came to clinic, we were able to provide an interpreter for them. So as I mentioned earlier, our first few clinics were staffed by community psychiatrists that we had recruited. Within a few months, we were actually able to recruit 5 residents from the Emory psychiatry program to begin volunteering. Our paper was published. We have recruited 5 additional faculty members at Emory. So we actually have gotten really good buy-in from the Emory community, which we're really happy with. The way the clinic works is that a resident will see a patient individually and then come out of the room and staff their patient with the attending, and then they would both go in to the room and come up with a plan with the patient. Like I said, our clinic lasts 2 hours. We have 3 patients scheduled per provider over those 2 hours. That kind of builds in some downtime in case someone doesn't show up. Then they still get to see 1 patient an hour, and that system has worked for us. The medical student role is not involved in delivering care. The medical students are essentially coordinating the clinic. So we've historically been in charge of screening patients at the primary care clinic every Sunday, and then once a month reaching out to our providers to figure out when we can hold a mental health clinic, and then scheduling patients to come on that day. There's also some opportunity for medical students to provide psychoeducation to both family members and the patients, both during the screening process and also during the mental health clinic itself, while they're waiting to see a provider or after their visit. So sorry about that. Give me 1 minute. Okay. So the first set of results that we were able to report from October of 17 to November of 18, we screened 664 patients at the primary care clinics on Sundays. Over 42% of the patients we screened positive for at least one of the 3 mental health concerns that we noted. Of those who screened positive, 86% screened positive for depression, 59% for anxiety, and 26% for PTSD. And if you just look at the numbers for all 664, those 3 rates are all higher than national averages, which is not surprising based off of the literature that we had seen about the prevalence of mental health conditions among refugees. But aside from the people who screened positive using the paper forms, we did some education with our providers and medical students at the primary care clinic to be on the lookout for patients who they think may benefit from mental health services, but who screen negative on the forms. And an average of about 2 patients per week were referred to the mental health clinic, even though they screen negative on the paper forms. From December of 17 to November of 18, we held 9 mental health clinics, so just under 1 a month. Our providers saw 45 patient visits, 32 of which were initial visits and 13 follow-ups. Of the 32 initial visits, 21, or about 2/3 of those patients, received prescriptions. The rest either didn't warrant or didn't want prescription medication. The way the medications work at our clinic, we do have medications donated to us by different organizations. So we do have some psychiatric medications on site, but we don't have a pharmacist there at clinic on Saturdays. So we would have patients return to clinic the next day on the Sunday primary care day to get their prescriptions filled. That we did that for about 6 months or so until we realized that the Sunday primary care clinic is just too busy to handle extra people coming in just to get medications refilled. So since then, we've been asking our providers to stick to the $4 list at Publix or Walmart because most of our patients are able to afford that price point, and it just makes the whole process a lot easier. Additionally, our patients just face a lot of complex situations that affect their mental health involving the legal system, psychological, social needs, and we're just not able to address all of them. So we've partnered with a nonprofit organization in Clarkston called the Center for Victims of Torture, which is better able to support these patients from a more social, legal status. They offer case management services free of charge. And as of November of 18, when we submitted the paper, 6 of our patients were referred to CVT. Since November, that number has about doubled. We have 11 or 12 patients now who we've referred to CVT for additional services. The Grady Health System in Atlanta is also kind of a blanket provider that doesn't require patients to have insurance, and we have referred patients to outpatient services at Grady. Like I mentioned, our secondary goal was to provide opportunities to medical students and residents to work with ethnically and culturally diverse patients. We have 5 residents, both in the psychiatry and medicine psychiatry combined program, who have volunteered with us so far, and a total of 12 medical students have volunteered, some of whom have graduated. Celia and I just graduated last week, and we have some medical students in the years below us who we've recruited, so the clinic will continue on after we leave. But this has been a really great learning experience for all of us to understand better how the role of culture interacts with psychiatric symptoms. We've gained some experience in screening and psychoeducation and coordination of care, and these kinds of basic skills that are required for community mental health have been a much appreciated side benefit of setting up this clinic. And it's something that's kind of sparked some passion in us, and we hope to continue doing similar work going forward. But this has not been without its challenges. Obviously, the number one challenge that we face is just the lack of financial resources. The CCHC is a nonprofit organization, so we receive funding from both the state and private donors, but we're always battling against the money monster. Another challenge has been the linguistic diversity of our patient population. Only 20% of our patients say that they are fluent in English, so it is a challenge. We do have providers who speak Arabic and Hindi, like I mentioned, but there are a lot of patients who we don't have linguistic match interpreters for, which is a challenge both for screening and for providing treatment. We don't do screening using any phone interpreters, but during mental health clinic days themselves, we have had patients who we used a phone interpreter. We had a Russian patient who required us to do that. It's doable. The problem is that it doubles the amount of time that a visit will take. So instead of a 45-minute visit, it'll take an hour and a half. So it has been a challenging meeting the demands of a linguistically diverse patient population. All of our providers are volunteers, residents, medical students, undergraduates, attendings. Everyone is there on a volunteer basis, and it's difficult coordinating everyone's busy schedules, which makes it so much better now that we have 7 attending psychiatrists instead of 2 previously. We're hoping that going forward we'll be able to hold clinic more frequently. There are also, like I said, a lot of other demands within the clinic. Not only the primary care clinic takes all of Sunday off the table, but splitting clinic time with the other specialty clinics is challenging. And in general, our group has a lack of expertise in cultural psychiatry. We're just not, haven't had the training that I think is required to deliver care to this patient population. And that's why going forward, we hope to partner with other departments at Emory, including the anthropology department. So next steps, like I said, secure additional funding for interpreters. The clinic has previously been awarded grants that have paid for interpreters to come to primary care clinic days. We hope to secure some of those again going forward. We have been thrilled that the Department of Psychiatry at Emory has really bought into this clinic, not only from a attending perspective, but also with the residents, and that's been great. But our patients are really complex and their needs go beyond psychiatric care. And that's why we're hoping that going forward we can recruit social workers and psychologists to come and expand the expand the services that we're able to offer. That's one of our goals going forward. And again, we're trying to address the mental health needs of our patient population more effectively by honoring this wide cultural diversity that we see. As I said, our screening tools, the PHQ-2, JD7, and the PC-PTSD-5, those are all in English, and that was definitely a limitation for us. We have introduced the Refugee Health Screening Questionnaire, which is a 15-item questionnaire that's been translated in a lot of the languages that we need. It's in Burmese, Arabic, Swahili, Amharic, Nepali. So there are tons of languages that has been translated into. So that's when a patient is unable to fill out the screening tool that we have now, we are slowly introducing the RHS to cover those patients. And finally, we're just hoping that this clinic will serve as a springboard for teaching medical students and residents about the intersection of culture and psychiatric illness. The Emory Psychiatry Residency Program is going to introduce a global mental health track for their residents to get more experience in this field. We're hoping that since the clinic has gone off the ground and there's been such great buy-in from the faculty and the residents, we hope that CCHC can be one of the main training sites for that track. One of the challenges that we faced was handing over the reins as Celia and I were both graduating, and that just had to do with finding medical students in the classes below and putting together documents to make sure that we had a clear transition and that everyone was introduced and exchanged phone numbers and all that. But we're hoping that the groundwork has been laid, and getting buy-in from the department was huge. So we hope that this clinic can exist into the future. I intentionally kept this presentation short. I was aiming for half an hour because I think that there are some questions that I'm sure you guys have. And like Amber said, if there's anyone who is trying to set up a mental health clinic of your own, then I'm happy to answer any questions that you have. So thank you very much. The article link is here, and I can share the PowerPoint after we're done here. So I'd like to open up to questions now.
Okay, thank you so much, Philip, and congratulations on your graduation. That's excellent. So, as I said today, I was going to have people send questions to me via text because that's what we did last time, and it worked pretty well. I do think we have a small enough group today that we can sort of have a little bit more of a discussion. So, I had a couple of people with some questions, so I'm going to turn it over to them if they would like to speak it out loud. I know people might be in a busy location. But Madeline Johnson, would you like to ask your question?
Hi, yeah, I mean, yes, my name is Madeline. I am a clinical psychology PhD student at Rosalind Franklin, so I think it's awesome that you have um, started this mental health clinic at your free clinic. We also have a mental health clinic at our school. It's run by psychology students, so it's great seeing, kind of interprofessionalism in other professions trying to also include mental health in their free clinics. But I guess being a clinical psychology student and kind of biased, you alluded to it a little bit, but including other departments in the care for your patients and how, I guess, moving forward you plan to do that.
Yeah, that's an excellent question. Thank you. One of the people that we've talked to about coming to volunteer is one of the department heads in the clinical psychology program here, one of the training directors. And he had the concerns that he had, and I'd be interested to hear your opinion on this also.
Yeah.
Just given the nature of the clinic and how we were really only able to hold a mental health clinic once a month, he was concerned about starting a patient on a treatment, like a psychotherapeutic treatment. They were only able to see each other once a month, and maybe there'd be gaps in between clinic visits. And his opinion was if we were able to have a program that the provider could see a patient once a week for 3 weeks in a row and have that as a commitment, that would be a better model for him as a clinical psychologist. So after talking to him, and his suggestion was a little bit more to go down the social work route, because he thought there'd be some challenges from a psychological perspective.
Yeah, I mean, yes, that is a good point. I suppose I slightly missed that part that it's once a month, which obviously as much as you can do is fantastic. The clinic that we have here is weekly, so we don't necessarily run into that continuity issue. We do have the psychology students make that weekly commitment for pretty much like the length of the school year. So it does require a lot of commitment on the volunteers' end, which I know is sometimes, it's difficult to recruit in that way and things like that. But yeah, it would definitely be more challenging if you could only have clinic once a month. Yeah, it's tricky when you're trying to start something and have continuity of care, because I know there's, at least for us, there's a high no-show rate.
Right. Yeah. So at your institution, are the clinical psychology students, is this a course that they take, or is it just like an extracurricular commitment that they make for a school year?
It's pretty much an extracurricular commitment.
Okay.
We do have, I guess it's attractive for students because they can count those hours towards the amount they need to apply for our version of residency, essentially.
Okay. Yeah.
So it's seen as like a supplemental rotation, since it's once a week for one night. So in that way, as long as you have a clinical psychology supervisor on site supervising, then you can count them for your hours.
Okay.
So yeah, it's that, for me at least, was the attractive piece, is that, the more hours, the more competitive you are.
Sure.
Yeah.
Yeah, definitely. And a meaningful experience, I'm sure.
Oh, for sure. Yes.
Yeah. Okay. And how long do you see patients for? Do you see them for the entire year, or is it more of a brief intervention?
It depends on the patient's needs. Some of them are more long-term, others, 6 to 8 weeks. With the, sometimes like treatment will just end because the patient no longer can attend at that, because it's on a specific night, specific time every week, things come up. So some treatments end early or abruptly. But we have the ability, I guess, to be flexible.
Okay.
Yeah.
Thank you for that.
Yeah, for sure.
Are there any other questions?
Sorry, Kevin told me I was muted. Kevin, would you like to ask your question? No. Okay, Kevin wanted to know a little bit more about the role of the medical students for care coordination versus the role of the students and the residents as more of a clinical role. So how do you incorporate both of those aspects?
Yeah, so I'll start by saying how they do it on the primary care side. So the medical students on the primary care side are a little bit more integrated into the clinical workings. So there are coordinators who schedule the other medical students to come, but the medical students see patients on their own, come out and present to the attending, and they go in together and come up with a plan. That's how they do it on the primary care side. On the mental health side, we really don't have medical students seeing patients as clinicians. The medical students on our team are responsible for screening patients at the primary care side, on the primary care clinic for those 3 mental health conditions. They're responsible for coordinating the clinic day in terms of telling the providers when and where to be at the clinic, scheduling patients for that day. We try to take as much of the load off of the providers, so the provider will take handwritten notes during the visit, and then the medical student will transcribe those notes into the EMR after the patient has left. But the medical students haven't seen any patients by themselves. Sometimes they shadow the resident while they're seeing a patient, but no medical students have actually conducted a visit at our clinic.
Okay, and as a follow-up question, was there a specific reason not to have medical students see the patients on their own, or perhaps lead the encounter with the resident watching them?
Yeah, so that's another great question. A lot of the medical students that we have are preclinical, so they haven't done their psychiatry rotation yet. So it'd be a little unfair to throw them in to the deep end like that. There also has been an issue of until we recruited the medical students below us, there really just wasn't enough of us. So someone had to be at the desk coordinating the clinic, and we just didn't have the manpower for someone to actually be conducting the visits themselves. Now that we have expanded and we have medical students from multiple class years below us, there may be some opportunity for that. There has been some discussion of offering this kind of clinic to the third-year psychiatry clerkship and saying if someone wants more experience doing psychiatric interviews with an interesting patient population, then while you're on your 6-week clerkship as a third year, you can come on a Saturday and volunteer. That's been mentioned, but there really hasn't been anything concrete that's been put forward.
Okay, great. Thank you. I have another question from Najiba. She's in a loud environment right now, so I'll ask it for her. So you mentioned that the next steps would be to instill a sense of cultural humility in providers. She was wondering how you all plan to do that, since you mentioned that the clinic sees a variety of people from different cultures. And she knows you mentioned potentially working with the anthropology department, but would you work together to create a training program for everyone? Just curious.
Yeah, no, that's another excellent question. This is something that we've kind of been battling because, and something that we've also done a lot of reading about to kind of understand what we're up against. Like you said, the patient population that we see is incredibly diverse. I know there are a lot of free clinics that see patients from diverse backgrounds, but perhaps more as a homogenous population. But our population comes from all over the world. So there's really no way to be culturally competent with our patient population because it's just overwhelming. So that's where we've kind of shifted towards this philosophy of cultural humility and realizing that we're never going to understand everything about how a person's culture interacts with their psychiatric symptoms, but just understanding that it does. In terms of how to train patients or train providers in that, well, that's definitely above my pay grade. Like I said, the Emory Psychiatry Residency Program is starting a global mental health track. So for everyone who's in the residency program, people who are interested in global mental health can take extra courses, take extra or special rotations, that can get them more training in that field. And traditionally, patient or providers and residents have gone abroad. I know there's a lot of residency programs that send their residents to refugee camps in Greece and Syria and Northern Africa. But we have a pretty unique population here in Clarkston where residents can get some of that experience just a 10-mile drive away from where they live. So we're hoping that the clinic itself can be one of the training sites for that track.
Great, that sounds really cool. Now, I'd like to ask if you could talk a little bit more about what cultural humility is, like compared to cultural competence. I know it's a term that I only recently was familiar with, so just in case others out there haven't heard it or have only heard it in passing, that would be helpful. Thank you.
Yeah. So my understanding is just, like I said, the idea of cultural competency suggests that as someone who is viewing a culture from the outside, you can become competent in that culture and understand how that culture works. But culture is a difficult thing, and if it's difficult to learn from the outside. So cultural humility is more of an appreciation for people's unique cultures and understanding that it's a very complex network and people from the same country can identify with different cultures. And it's just the idea that if you're viewing someone else's culture from the outside, then you can ask questions and learn how they interact with their culture, with the understanding that you're never going to fully understand what their experience has been.
Awesome, thanks. And we have another question. Is there a way that you plan to measure cultural humility as an outcome?
That's a good question. Honestly, that's not something that we've thought of. I'd welcome your suggestions, though. That's an excellent point.
Okay, who else has a question? Feel free to unmute your mic and speak up if you like.
Hi, this is Madeline again. This is less of a question, more of a comment, just with the PHQ-9 and I know you use the PHQ-2, but the PHQ-9 is validated in several other languages. I don't know if you had looked into that. We use the PHQ-9 at our clinic, and we give them both in Spanish and English. I know you mentioned different languages that are in your community. And we also on the interpreter side, we partner with a local interpreting school. And so they, part of their certification and requirements, they need a certain number of hours to be able to be certified as an interpreter, and so sometimes these volunteer hours are ways that they can get them, etc.
Oh, that's great. So I'll definitely look into that if there's one in Atlanta.
Yeah.
And the PHQ-9. Yeah. So strangely, we don't really have a large Spanish-speaking population among the patients that come here, and my foggy recollection is that the PHQ-9 is translated in a lot of languages, just not a lot of the ones that we need.
Yeah.
Like French and German and Russian, and these are not really languages that we needed.
Okay.
But yeah, that's something that we looked into. And the refugee health screening questionnaire, it comes up in a lot of a lot of papers, we couldn't find anything that talked about it being validated in non-refugee immigrants or non-refugee, non-English speakers. So we were just a little bit hesitant to introduce it. But ultimately, I did talk to someone at a like a refugee health symposium, and they said that it's totally fine. So, so we have paper copies ready to go in the clinic, and if a patient's unable to fill out the English screener, then we just have our volunteer make a photocopy of the one they need, and hopefully it's one of the ones that we have there.
Yeah. Okay.
But I'll definitely look into if there are any interpreting schools here. That's a good idea.
Yeah, it's a nice reciprocal because they need hours, and it's sometimes challenging if they can't find a place to get them necessarily.
Cool.
Okay, is there anyone else with a question they'd like to ask right now? Okay. Oh, Aisha.
Yeah. Hi. So I'm Aisha. I'm a second-year occupational therapy student at Washington University in St. Louis. And I had a question about the nonprofit. You mentioned that you had referred some of your patients to this outside nonprofit, and I realize that an effective introduction to like a new resource can be difficult. So I'm curious what that transition looks like, and how do you ensure follow through?
Yeah, that's an excellent question. That's a problem that we ran into initially. Basically, the contact people at the Center for Victims of Torture came to the primary care clinic to introduce themselves, tell us about the services they offer, so that whenever we came across a patient on the mental health clinic who fit their criteria, we could explain a little bit about the clinic, about the Center for Victims of Torture to them and what services they offer. And there's a referral form that CVT has that basically is name, country of origin, date of birth, what languages do you speak, and then there's a section for the provider at the mental health clinic to say why are we referring them to the nonprofit. Originally, the problem that we ran into was that we were calling patients on the phone and trying to explain over the phone what CVT was and whether we had their permission to refer them there. Ultimately, the language barrier was just too great, and we weren't able to effectively explain what CVT did and what services they offered over the phone. So we thought we were doing a good job, and then we were sending CVT all these referral forms, who would then call the patient, and the patient's like, who are you? What are you doing with my phone number? So we nixed that and decided that only patients who we saw at mental health clinic would we talk to in person, and we've had more success doing it that way.
Cool. Thank you.
Yeah.
Other questions? Okay, I have a question. So, after trying to start a couple of initiatives at my own student-run free clinic here in Austin, I know that there is always some unanticipated challenges, like little things or logistical things that you would never even think to plan for. I mean, are there any sort of, obviously there's the big challenges of language and all of that. Are there any smaller things that you can think of that other clinics could benefit from learning from your experience?
The thing that comes to mind at first is having a good relationship with the other providers at the clinic, because whenever we were trying to start something new, the initial response, aside from let's have a mental health clinic, everyone was kind of on board with that. But every time we tried to do something a little bit different or something that shook up the clinic a little bit in terms of the operational workflow, the initial answer was always no. And then we just kind of had to sit down and explain what we wanted to do and if they had any suggestions about a more efficient, better way to do it. So those kinds of just relationship things, I think were initially caused some headaches, just because we're trying to do this. This is the best way to do it. Just let us do it. And we had to understand that we were changing the system a little bit. I mean, introducing the screening process at the primary care clinic was a little bit of a battle, figuring out when to talk to patients, because there was a way that they liked things to go. So just finding a way that we could do it more seamlessly, that took a little bit of time. And I do think the other thing that came up was the transition of power, essentially. So when Celia and I were entering our 4th year, and we're trying to figure out a way to pass on this clinic to the younger medical students, we really had to think ahead in terms of going to the student activities fair in August and telling and really selling the clinic to the first and second and third years, and sell it not only as an opportunity for them to get involved with a pretty cool organization, we thought, but also kind of adding a little bit of an element of a CV aspect to entice it a little bit. You do have to kind of utilize that to get people on board, and then be very diligent about documenting what you do on a week-to-week or month-to-month basis, so that when March, April rolls around and you're backing away from the clinic a little bit, everyone who you've recruited knows what to do. So I'd say start about a year ahead of time when you're planning to pass the clinic on.
Yeah, that's a great suggestion. We're having similar discussions about other initiatives as well at our clinic.
Are there certain things that you've run into that were difficult that?
Yeah, I mean, it's a little bit different for my school because we're a new school and I'm in the first class at UT Austin. So we're having to do everything from scratch. And so trying to figure out, how are we going to recruit new directors, like which year of people, because our years are different. We do our clerkships in our second year instead of our third years, like which students in that year are going to be directors or taking over this or that project. So it's a little bit different, but I agree with you that starting early on planning that is really key. And selling the CV thing is really key. Another thing that we found that was helpful for us is people who wanted to do projects that would count for classes and things like that. They want to do that just at our clinic. I don't know if that would happen at yours since it's a smaller mental health clinic once a month, but we would allow them to do a project if it was something reasonable. They could do a project for a class or whatever to get credit at our clinic, but they had to volunteer 3 times that semester in order to use our space for that. And that really helped, actually. So, selling the CV thing, giving other incentives for participation is always good for a busy medical student volunteer base.
Yeah.
Any other questions that anyone has? Okay, thank you all so much for attending, and thank you again, Philip, for leading that great discussion for us and letting us know all about the clinic that you helped create. For all the participants, I'm going to send out a link to a survey after this is over, and I'll also include Philip's slides as well. Please fill out the feedback survey. We really appreciate your feedback so that we can create better other great programs in the future to help connect all the student-run clinics in our country, share our research together. All right, so that's about it. Everyone have a great night.
Thanks, everyone.
I keep forgetting to unmute myself. Thank you very much, Philip. Everyone's gone.
Yeah, thank you guys. I really appreciate it.
Yeah, I really appreciate that. If you could send your slides to me or Jessica, we'll send it out with the survey.
Sure, I'm happy to do that.
Okay, that was really awesome. Thanks. I've been trying to start up more mental health initiatives at our clinic, and it's been a slow process, mostly because people who you want ask questions to just don't respond to emails. I think this is
one of the most important thing for us was relying on the board members of the clinic to know a psychiatrist, because like I said, we really didn't get buy-in from the Emory department until later. So we were able to get it off the ground and show that like we had a working infrastructure, and then we could take it to the department and be like, hey, do you guys want to get on board?
Yeah, definitely. Connections help.
Yeah.
All right. Well, have a good night. Thanks again.
All right. Thanks a lot. You too. Take care.